10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0.
Well, welcome everybody around the world, and welcome to our first episode of 2021. Uh, crossing the midway mark of our Rising Star series as well has been a terrific achievement by the team. We wanted to thank all the audiences around the world to be a part of this special series called Rising Stars in Ophthalmology. It gives us immense joy to also be a part of this whole community of ophthalmology. We've been able to kind of sail through this pandemic and still sailing in many ways. Uh, and thank you to all our wonderful celebrity panelists and our speakers for being a part of this series. For the folks who weren't with us the last time, Rising Stars in Ophthalmology is a season one is a 9-episode interactive series that will focus upon bringing you all absolutely new and innovative technology and one of the best clinicians, surgeons, and orators around the new age of ophthalmology, as we call it. This program is being aired on our website called risingeyestars.com and on our Facebook and YouTube channels. We do love questions, and any of these platforms, if you do deem fit, if you want to ask a question, please feel free to go ahead and ask. The other point is, since this is a global event and timing sometimes may not match where you're watching this, all the episodes have been recorded and shared on our risingeyestars.com website. So if you should want to go ahead and watch it, but only on our website, please go and watch all the old episodes, because remember, old is gold. Uh, as of today, our episode, we have an absolutely stunning star cast of celebrity panelists and uh, and a very special speaker who's very dear friend of mine. To introduce the same and to introduce the sponsors as well, I would love to invite Jennifer Lowe, my co-moderator, who's been extremely helpful and extremely generous in her approach towards the Rising Stars in Ophthalmology. So Jennifer, all yours. Thank you so much.
Thank you so much for the kind words, Ashvin. It's a complete honor to be able to work with you and the rest of the team in providing such an exciting broadcast to our audience every month. So I first wanted to start off by thanking our sponsors. And we've prepared a PowerPoint to again extend our thanks to the sponsors here you can see. And then now, with also without these sponsors, I'd just like to highlight that this wouldn't be possible to bring you this broadcast. So thank you again to all of our sponsors that have supported us through these past few months. So next, I would like to actually introduce our celebrity panelists and then our Rising Star speaker. So I have a PowerPoint I prepared. Okay, so here we go for our celebrity panelists today. We have first on the list the famous Dr. Marguerite McDonald. She is a clinical professor of ophthalmology at NYU and Tulane University. She's a cornea, cataract, and refractive specialist at OCLI Vision Institute in Long Island and the director of their Dry Eye Center of Excellence. In addition, she has actually performed the world's first laser vision correction procedure in 1988. And if you haven't heard her story of this, you must listen to her podcast. It's absolutely amazing and really changed my perspective in laser vision correction. So I highly recommend it. And she was also the first woman president of ASCRS and ISRS. So we are honored to have her presence here tonight. We also have Dr. Parag Majmudar, who is a fellowship-trained corneal and refractive specialist at the Chicago Corneal Specialists in Chicago, Illinois. He's an associate professor of ophthalmology at Rush University in Chicago and also was former co-director of the Corneal Fellowship. He's active in clinical research and a highly regarded lecturer and instructor on the subjects of corneal and refractive surgery, and is also an active member of the Cedars-Aspen Society. And last but not least, we have Dr. Edward Holland, who's the director of cornea services at Cincinnati Eye Institute and professor of clinical ophthalmology at the University of Cincinnati. He's a former president of ASCRS, and he's also received numerous national and international awards, including the Castroviejo Award from the Cornea Society in 2013. And once again, I'd like to thank all three of our wonderful celebrity panelists for sharing your expertise and time tonight. So next, I'd like to introduce our rising star for the evening, Dr. Biren Mikpara. Actually, let me go back to this amazing photo, by the way. I think this is so cool. I mean, it really looks intense. I don't know what you were doing here, Dr. Mikpara, but it definitely could be along the lines of a heart transplant or something. It looks very intense. So I definitely can't wait to hear your story about this, but I love the photo. And whoever your photographer was obviously amazing. It's a very beautiful shot. And I love the surgical tray. So Dr. Mikpara comes to us. He did his undergraduate training at the University of Illinois in Chicago, as well as medical school there. He did residency at Baylor and a fellowship in cornea external disease and refractive surgery at the University of Colorado. He is the co-director of refractive surgery and clinical assistant professor of ophthalmology at Wills Eye Hospital. He enjoys life with his wife, Shaylee, and he likes attending ASCRS in San Diego. And an interesting fact about him is that he's a level 3 sommelier. So we hope to spend many more evenings as we learn from him in many ways. So thank you again for preparing a wonderful presentation. And I look forward to our evening. Thank you.
Thanks, Jen. I appreciate that very warm welcome. So we've got a bunch of great resources at Wills, but I think the greatest thing that we have is we have our own in-house photographer. His name is Roger Barone, and he'll come and do a photo shoot of you whenever you want. So it's great.
Wow, amazing.
All right, let me pull up my slides. So again, thank you, Jen, for that great introduction. Thank you to Jen, Ashvin, and Bill for the honor to speak tonight and inviting me. And a very, very big thank you to my amazing celebrity panelists here. It's just an honor to share the screen with you. And finally, thank you to everyone joining us tonight. I hope you'll enjoy my talk. I hope you find it interesting. And what I'll be talking about are recent innovations in anterior segment surgery. These are my financial disclosures, none of which are relevant to this talk. I will be speaking on the off-label use of both sutures and IOLs for secondary fixation. So I just wanted to acknowledge that. You know, anterior segment surgery, anterior segment reconstruction is something that I really enjoy doing. I just find it really rewarding to take something that's anatomically broken and fix that into a more functional form. There's a lot of variety in the surgeries, from iris repair to IOL work to corneal transplantation. And there's a lot of room for creativity and innovation here. So I'd like to start the discussion first with Dr. McDonald. Dr. McDonald, I've seen you give plenty of very interesting talks on things that you've innovated, new technology that you've trialed. And I'm just curious, I'd love for you to tell us a little bit about what your thought process is when you try these new things. What's going through your mind when you're doing that evaluation?
Well, if I am involved in the innovation or the clinical trial, then of course I have firsthand knowledge of the safety and efficacy. And so I already know who the appropriate patients are, what the contraindications are. If it's something that I did not develop, didn't have a hand in, but I want to incorporate it, or I'm considering incorporating it into my practice, I look at the peer-reviewed literature and I call trusted colleagues who are experts in the new technology, who I know will guide me very honestly and willingly. You know, I still have great faith in the peer-reviewed process, and I know that a lot of people are frustrated. They don't want to wait to get their things into a peer-reviewed journal, but that process is very, very important. And the journals have learned to speed up so that it's not quite as slow as it was a few years ago. But you can hang your hat on the peer-reviewed process and the data that you learn there. So that's sort of how I think about things.
Great, thank you. You know, when it comes to surgical technique, it seems like nowadays there's new techniques coming out left and right, and sometimes, you know, we're left to maybe do a little bit of self-evaluation, or you know, again, lean on our colleagues. So, you know, when I'm considering trying something new, my basic thought process is, you know, what am I doing right now, and you know, why am I doing it that way? Why did I like that? And then I try to think about, what don't I like about it? What are the shortcomings of my current technique? And then simply, you know, what can we do to improve it, or what needs to be improved? Can I make this more efficient? Can we make it more safe? Or can we make it better? Can we improve the efficacy of it? And to kind of illustrate these points, I want to go through kind of 3 cases. A lot of this will be video based, but the first situation is going to be where we encounter a patient with a dislocated IOL. So this is a patient of mine. I did his cataract surgery. He was happy afterwards. But then a few months later, he was involved in an altercation. The details are a little vague, but he got punched in the eye. And afterwards, he was left with this dislocated IOL encapsular bag complex. And then that's the photo of him on the screen there on the right. So Dr. Munchmuther, when you have a patient that, you know, comes in with a dislocated IOL, dislocated bag, how do you decide how you're going to fix this? Do you like to reposition? Do you like to exchange? What's the thought process there for you?
Most of the time, thanks for the question. Most of the time, I would say that if the lens itself is good, maybe the quality of it, there's no opacification or other material problems. If the patient had seen well, his vision was good before the incident, I'd do my best to try to maintain the lens in situ rather than exchange it. It's certainly a lot less technically, you know, difficult to keep the same lens as opposed to exchanging it. So when you have a situation like this, which is a 3-piece lens or even a single piece acrylic lens, that it's in the bag and there's a bag lens dislocation, my first thought here would be to try to maintain the same lens and just try to secure the lens to the eye, in most cases with scleral fixation in this situation, rather than try to exchange it.
Great. Yeah, you know, I'm 100% agreement with you. I think, you know, this is the 4th point on the screen, but I think the most important thing is, if the patient's happy with the current IOL and the IOL is healthy, I like to try to leave it. Other things that I look at, you know, what's the status of the bag and what's the status of the IOL? Is it in the bag, and is the bag intact? If that's the case, it's certainly, at least in my hands, easier to refixate that. I like to have some remaining zonules. So if the zonules are all gone, it can be a little tough to make that refixation stable. But if you have some remaining zonular support, it makes it easy. And again, like you said, the IOL, is it refixatable? I don't know if that's a word, but is it lassoable? That's my technique that I like to use. 3-piece IOLs, and again, most open loop single piece IOLs are lassoable. The plate haptic lenses may be a little bit tougher. And then the other thing is, you know, is the current IOL going to be tough to remove, or is it going to be very invasive to remove? So for example, if you have a PMMA IOL, instead of making a 7mm incision to get that out, maybe it would be worthwhile to try to refixate that. Now, if the IOL is too dislocated, like here, I have a patient that the whole bag and the IOL is in the AC. I don't think we're going to be able to refixate that. So then we may opt for an exchange. If the patient wasn't seeing well or the lens is not healthy, then we'd exchange it. Sometimes if you have a large Sommerings ring, that can get in the way of a refixation. Sometimes that can kind of migrate anteriorly and result in some iris chafing or perhaps some UG. So if there's a huge Somring's ring, sometimes I won't try to refixate that. And then if there's a bunch of vitreous in the way, we are going to be passing needles and sutures through this. And if there's a lot of vitreous in the way, sometimes it's best just to do a good, near complete vitrectomy. And if you don't have that vitreous behind you, almost acting like a third hand, it becomes a little bit tougher to refixate things. So sometimes you may need to exchange. So as far as refixation goes, this is how I used to do it. So I used to do a lasso technique where I would take a 27 gauge needle and a double arm tenoproline suture and a long curved needle and basically lasso the IOL that's been dislocated. I'll start out by making marks, and the marks are the intended points of scleral refixation. And you're kind of at the mercy of where the IOL is sitting. So I'll aim about 2.5 millimeters posterior to the lens, and I'll make that mark a few millimeters distal to the optic haptic junction. And what I'll start with is I'll take a 27 gauge needle just posterior to that mark, go behind the haptic. So get posterior to the haptic, puncture through the capsular bag. So now we're going through the capsular bag. You'll sometimes need some counter traction there. And then from across the eye, make a paracentesis, use a tenoproline suture on a needle, dock it into the hypodermic needle, and then pull it out of the eye. We'll repeat the exact same step, but this time going just anterior to our mark in front of the haptic to the IOL, dock the other end of that double arm proline suture, and externalize this. Once we do that, we've essentially lassoed that IOL with the suture. We'll do the same thing to the other side, tie the suture down. I'll leave the tails long to try them, lay them flat against the sclera, close the conjunctiva, and you're done. So this was a quick video, not too many details there. This isn't going to be the highlight of the talk. This is just kind of giving you a background on how I used to do it. So what were my issues with this technique? I think first and foremost is this long needle. We're taking this long needle, either curved or straight, and we're passing it across the entire anterior chamber. And sometimes things can get a little out of control. So here's another patient, and this is a right eye. And because of where the haptic is located, that fixation point is going to be infranasal. Now, infranasal, we run into the issue of the nose. And that can sometimes get in the way depending on the patient's anatomy. So I'm going to go ahead and make my scleral incision go underneath the haptic through the capsular bag. We're going to go ahead and dock our proline needle into there. And now as I'm externalizing, the nose is really getting in the way. And as I'm lifting up on the needle to avoid the nose, the other end of the proline needle goes down. So as you lift up, the other end goes down, and it's just rubbed up against the entire IOL. It was basically a side swipe collision, and that's just a mess at that point. At that point, we have to abort the refixation, remove that lens, and go ahead and do an IOL exchange. So that's one issue. The other issue is we're using tenoproline, right? So tenoproline generally is what I'm using in this situation. Tenoproline can degrade over time, and if it degrades, it can break. And if that suture breaks, we're going to have another dislocated IOL. And then the final issue I have is the need for a conjunctival peritomy. And I don't know if this is just me, but I really don't like making conjunctival peritomies. They take time to make, then you have to cauterize them, then you have to close them, they bleed, the eye looks like a mess afterwards, patients don't like it, they complain of the sutures, and even down the road, patients seem to find this uncomfortable. So Dr. Holland, am I just being a whiny millennial here, or is there a legitimate long-term concern to these conjunctival incisions from a conjunctival standpoint, from a limbal stem cell standpoint? Any concerns with all these peritomies that we're making?
No, I think you bring up some good points. I mean, I think we've learned that we should value the limbus, and any incision we make in the conjunctiva, we want to go back, about a millimeter or two. And so no matter what surgery you're talking about, I think, preserving the limbus is important. And, you may find that this eye will need additional surgery, right? May develop glaucoma down the line. And so I think if you have a technique that you can avoid major conjunctival surgery, I think you're doing the patient a great service. So I applaud you for looking at a a better way to do this procedure and preserving the conjunctiva. The second, concern we have besides cosmetic, and I guess we already mentioned limbus, is creation of dry eyes. So if you make too large conjunctival perimeters, we're going to get conjunctival scarring. These patients are often older. You're going to create some ocular surface disease by your previous technique. And I know we're going to have a better way to do this.
Thank you. Appreciate you legitimizing my gripe. All right. So, I do think there is a new innovative technique out there, and I can't take credit for coming up with this. I do think we should always give credit where it's due. And two brilliant people, Dr. Sergio Canabrava and Dr. Kathy McCabe, came up with a new way of scleral fixation using Prolene suture, whether it's 5-0 or 6-0 Prolene. And what they do is they create a flange on the tip of the suture and use that to fixate whatever IOL you're using into the sclera. And specifically, Dr. McCabe describes what's called a belt loop technique for refixating a dislocated IOL. And that's what I'm going to highlight here. So as far as equipment that we need, you do need a nice set of micro instruments. I like to use the set by MST. You need a needle. A 27 gauge needle is okay. I like to use a 30 gauge thin wall needle. For this particular technique, 5-0 or 6-0 Prolene is fine. It doesn't matter what needle you have on there because you're going to cut them off. And then you need low temperature handheld cautery to create that flange. So here we have another patient with a loose IOL capsular bag complex, as you can see here. This one's also sitting a little posterior as well. So in order to improve visualization, what we'll do is we'll put in some iris hooks so that we can visualize that haptic, and also put in a trocar and use a vitrector to do a little vitrectomy, but also to move that lens a little anteriorly so it's more accessible. We have that same mark, 2.5 millimeters posterior to the limbus, and we'll take that 30 gauge thin wall needle and advance it behind the haptic of the IOL, and then through the capsular bag using a micro holder as counter traction. But that micro holder also has one end of this 5-0 Prolene suture in it. So we'll take that 5-0 Prolene suture and thread it through the lumen of the needle. This is one of my first cases. I'm probably threading it a little bit further than you have to, but I just wanted to be, a little bit more cautious. We'll externalize that. And you don't really have to cauterize that either, but I did that just so I wouldn't lose the suture. And then we'll work on the other end. This is a tip that Dr. McCabe taught us. If you cut that suture at a little bit of an angle, it makes it a little bit easier to feed into the lumen of the needle, almost tapering the edge of it. So this second needle pass is now anterior to the first, and it's anterior to the haptic of the IOL. So we'll go ahead and feed that in. And as we externalize this carefully, what's going to happen here is we're creating a loop. Now that loop, as we pull both ends of the suture, is going to snare the haptic of the IOL and essentially lasso it, just like the last technique, but we're not passing a long needle across the surface of the eye, and we've left the conjunctiva relatively undisturbed. We'll do the exact same thing to the other side, and now what we're going to do is tighten the loops. So methodically, we'll cut the tails of the suture progressively shorter and shorter, cauterizing the tip more and more. And as we're doing this, we're tightening the loop, we're tightening the fixation, and we're centering the IOL. And I like to do this with the eye pressurized, so we have an AC maintainer there. And as we get closer to the ocular surface, you just have to be careful not to burn the surface. And also a cellulose sponge is helpful here to dry up any liquid so that the cautery works. But eventually we're left with 4 little small nubs that we make flush with the sclera, pull the conjunctiva over them. We'll go ahead and close the sclerotomy, and we've refixated that lens in a fairly non-invasive fashion. So I thought that was a neat technique. The concern that I have, though, is what's the stability of this? So Dr. McDonald, I'd like to go back to you. When you see this IOL fixated like that, do you think it's going to be stable, both in the short term as well as long term?
I think short term, yes, but the technique is new. It's just been developed, so only time will tell. And also, the patient, of course, has to be cautioned against eye rubbing, et cetera. I'm hoping, if I had to take an educated guess, I think it will be stable long term, but you just have to follow a few of these people and let the year.
Yeah, I'm not sure. You know, I've had one patient in the short term that actually ended up pretty tilted, and I had to go back and just remove the lens and put a new one in. The remaining, and I haven't done a ton of them, probably about 15, 20. They've so far done okay, but you know, I started doing this about a year ago after I heard Kathy talk about this at ACOS. So, like you said, time will tell.
Huron, do you see that the conjunctiva then grows over the cauterized edge of the proline? Because obviously you have a foreign body tract from external to internal. You know, we first started doing these many years ago using tenoproline and tying a knot under the conj. You know, one of the problems we had was erode, and there were cases of endophthalmitis in addition to having tenoproline not last very long. So I think it's very important that the conjunctiva is above and not any of the proline protruding.
Exactly. And I think the other key is to try to actually bury that flange within the sclera, to try to get it actually into the sclera. And if you can do that, or at least get it as flush to the sclera as possible. And in those situations, it conjunctivalizes nicely right over it. And I fortunately so far haven't seen any erosion through that.
And Viren, if I may ask a question for the audience perspective, what is the needle size that you're using to draw these sixoprolines out?
So you could either use a 27 gauge needle or the 30 gauge thin walled needle by TSK. Using a 30 gauge regular needle, that becomes tough to feed it through, especially if you're using 5-proline.
Okay.
I think Sergio describes a 29 gauge needle in his technique. So I think anything between 27 and 29.
Perfect. Margaret?
Now, Biren, have you ever cauterized it down so far that you lost it? It slipped through the sclera.
Not yet so far. When doing the Yamani technique, I have lost the haptic in the sclera, but so far with this, it hasn't happened yet. But that's why even when I have this long tail out in the beginning, I would just cauterize the tip right away, just so I don't lose it. Great, thank you. Thanks for the great discussion. So switching tracks a little bit, let's say the IOL is not refixatable, and then we're going to do an exchange, or we need to put an IOL in an aphakic patient in the absence of capsular support. This is a portion of our field that's really been gaining popularity, I think, recently. On the left, we have a photograph of me doing intrascleral haptic fixation, as we alluded to earlier, first described by Dr. Shin Yamani. And this technique has become wildly popular. And it's actually my technique of choice. On the top right, we have the Agarwal glue technique. And actually, I'm not that great at this. So I lifted this image from the internet. It's one of Ashwin's. So thanks, Ash. And then on the bottom right, we have the use of Gore-Tex suture to fixate IOLs with eyelets to the scleral wall. Again, that's off-label use of Gore-Tex suture. And this has become popular as well. In fact, our retina service at Wills, this is their go-to technique. I think we live in a time where we have so many different options, so many great techniques. And Dr. Mosmer, I'd like to go back to you. If you have a patient that doesn't have capsular support, you need to put an IOL in. How do you decide which technique to use? Or do you have kind of preferred go-to technique that's what you're going to do every time?
No, so it definitely depends on a case-by-case basis. But for the most part, I think in general, if we divide them into scleral fixation versus iris fixation, I probably prefer scleral fixation for a lot of reasons. I think iris fixation, there's a higher incidence of UGH, uveitis glaucoma hyphema syndrome. The lens may not be as stable of a platform. I find that scleral fixation is definitely much more stable, whether you're using any of the techniques, Agarwal's technique or Yamane's technique, or proline fixation of an old PMMA lens to the sclera using Hoffman pockets or something along those lines. You have a lot of different ways to do a scleral fixation. I just find that those are generally my preferred approach compared to an iris fixation. But I've done all of them, and they all work to some degree. But I prefer scleral fixation.
Yeah, great. I think I'm in agreement with you too. And the other thing I always like to mention when I give a secondary IOL talk is, there is a role for an ACIOL. A well-fit, well-placed ACIOL in the hands of someone that may not be comfortable doing some of these other methods of scleral fixation, I think it's perfectly acceptable. So, rather than venturing outside your comfort zone, if an ACIOL works for you, I think that's an
I agree.
acceptable thing to do.
I agree with that as well.
So, when we're doing these techniques, we're trying to avoid problems. At least I'm trying to avoid problems or minimize the chance of them. So with these Gore-Tex suture techniques, we know that suture erosion, it can be a real issue. Now, normally it's the knot that becomes exposed, but this is one of my patients that I did a Gore-Tex MX60 on, and it was just the line of the suture that eroded right through the conjunctiva. So that was frustrating, and these can be a little tough to fix. This was an even worse problem. This is a patient that was referred into me for suspicion of a conjunctival mass, but instead what that really was the knot of a Gore-Tex suture that not only eroded through the overlying conjunctiva, but also eroded through the underlying sclera, causing a full thickness scleral perforation. You can see the pupil peaking there, and that required quite a bit of extensive repair. There's also issues that have been reported with eyelet fractures. So this is a patient of mine that was referred in that had a Gore-Tex sutured MX60, and you can see a tear in the eyelet. And there's been a series of these recently reported of this exact complication happening. And then finally, intrascleral haptic fixation, again, popularized by Dr. Yamani. This has become very popular nowadays, especially amongst our trainees. They're very enthusiastic about learning this technique. So much so that, Dr. Yamani's name has become a verb. And we now say we're going to Yamani this IOL. But there's a pretty steep learning curve to this. And we have excellent trainees, but we kind of see everything when it comes to what can go wrong with this lens. These haptics, especially depending on what material is being used, can kink or break off right there, as we see. And there's definitely an issue with IOL decentration. If you don't have your scleral tunnels equally spaced apart, equal length, equal angles, you can very easily get IOL decentration. Sorry about that. So here we have another patient, another case. This is a patient that had an ACIOL placed, but it really wasn't positioned perfectly. There's a significant amount of iris rubbing, a lot of inflammation, occasional hyphemas, and there was also some iris trauma at the time of implantation. So here we have an ACIOL that we need to explant, and in order to do so, we need a large incision. So we need to create about a 6 millimeter incision to get that IOL out. So then the question is, what's the best IOL to put in to replace it? In this situation, I like to use a CZ70BD. Now that is a large, stable IOL with a 7 millimeter PMMA optic. And in a normal situation, I wouldn't use that because you can't fold it and get it through a normal wound. But here I'm making a 6 millimeter wound already. So what's another 1 millimeter, I guess, especially for the benefits of this lens. And we'll talk a little bit about this lens in just a second. And then what's the best technique? We can use suture, we can use Gore-Tex, we can use tenoroproline, but we can also use Dr. Canabrava and Dr. McCabe's technique with a little bit of a modification and use 5-O-Proline to fixate this. So as far as this particular surgery goes, what do we need? It's the same instrumentation as last time, the micro instruments, the 30 gauge thin wall needle, handheld cautery. Here we're gonna need 5-O-Proline though, and we'll need the Alcon CZ70BD where we have a little eyelet on the haptic. And the reason we need 5-O is we need a flange to engage that eyelet and not come through it. And it gets hard to create a big enough flange with a 6-O. So you're gonna wanna use a 5-O when you do this. All right, so here's our patient. We're gonna make marks 180 degrees apart. We're gonna basically fast forward through the IOL removal parts. It got a little dicey. It was kind of stuck in the iris. There was a little bit of bleeding, but we got it out. What we're going to do is we're going to take one end of our 5-O-Proline, cauterize it, and we're going to feed the other end through the eyelet of that IOL, and we're going to feed it posterior to anterior so that that flange that we created engages with the eyelet. We'll do the same thing with our second 5-O-Proline, again, passing it posterior to anterior. And then we'll take our 30 gauge thin wall needle, about 2.5 millimeters posterior to the limbus, enter the sclera, and feed the non-flanged end into the lumen of that needle. And we'll just go ahead and feed it in a few millimeters, externalize it, and then start working on the other side. Again, we'll take the 30 gauge thin wall needle, 2.5 millimeters posterior to the limbus, and feed it into the lumen. It's a little bit awkward here. I don't know if it's my left hand or that annoying air bubble that's getting in the way. But eventually we get it to go through, and we'll externalize both ends. At this point, all we have to do is slide the IOL in. We'll carefully do that, position it behind the iris. And this is a combination of pushing the IOL into the eye and pulling the 5-0 proline out of the eye. And we'll just kind of push and pull back and forth. And the nice thing about this is we don't have a bunch of suture that we have to worry about getting tangled. We don't have to worry about, for example, if you're suture fixating this, are the tails of the suture going above the haptic? Are they going below the haptic? Is one above, one below? You don't have to worry about any of that with this technique because it's just one line of suture. And just like in the previous surgery, we'll cut the tails of the suture and then gradually cauterize, cut and cauterize, shortening little by little, tightening the suture as we go, centering the lens. And again, we're going to push that flange into the sclera. And then for completeness, we're going to perform the Agarwal 4th row pupilloplasty here to try to give the patient a more physiologic pupil. And then in the case, we have a nicely centered IOL, quite stable, and a fairly round pupil. So Dr. Holland, I'd like to come back to you. Especially for someone that, perhaps may end up doing an EK on top of this, because, as you know, sometimes these ACIOLs can cause corneal edema. We do a lens exchange and then do a DSEC. I'd just love to hear your thoughts on this particular technique.
Well, I mean, this is, it kind of is a flashback. I'm one of the older guys on the call to remember the days when we had to take out all the anterior lenses. Unfortunately, we don't have to do that, but really that's what caused really an explosion in the need for keratoplasty in the United States, is that, there was not a lot of keratoplasty done until anterior chamber lenses were invented. And, we ended up taking out most of them over the time. And so we actually did some of the very early work on transsclerally suturing posterior chamber lenses. We liked your IOL the selection CZ70BD, but we were using double R and proline, and your comments on proline getting caught and getting on the wrong side of the haptic and things, it just brings back nightmares. So I think this is a beautiful technique. I think that lens, if you have a large enough incision, why not use that lens? If you have to make a big incision, that's the most stable lens. It's going to be great for doing a DMAC because it's going to have a stable anterior chamber. And, I think it's a beautiful technique to fixate a posterior chamber lens.
Thank you. I appreciate that. All right, we're going to switch gears for our last case. Instead of talking about IOLs, let's talk about the iris. And we'll use the setting of a patient with TAS. So this is a patient that had uncomplicated cataract surgery by a very good local cataract surgeon, and a Symphony extended depth of focus IOL was placed. The surgeon used intracameral moxifloxacin for antibiotic prophylaxis, and unfortunately, the patient developed TAS afterwards. And a month after surgery, the patient still had poor vision, count fingers. As you can see here in the photograph, there's severe corneal edema. And this patient has not had dilating drops. So that is the natural state of the pupil. He's got a tonically dilated pupil. Fortunately, the other eye had a good result, but we have an issue here. So I'd like to go back to Dr. McDonald. I'd like to get your thoughts on intracameral antibiotics. Do you use them? What are your thoughts on them?
Well, I actually don't. I had an extremely bad experience a few years ago. And this was very quickly in the middle of the night doing an open globe. And this was before we knew about vancomycin, hemorrhagic occlusive vasculitis, et cetera. So open globe, I asked the pharmacy to send up some intracameral vancomycin, and they sent it up. I injected it. The eye began to bubble. All the tissue began to turn white. I irrigated it out and found out that it was 70,000 times stronger than it should have been. And the retina went into shock for a year. So that scarred my soul, that experience. Now, admittedly, if you get it from a fairly reliable source, it can be mixed up, and most cases do not result in TAS. But in August of 2020, the FDA sent out an alert about people making up their own moxifloxacin, whether you did it from a bulk drug or whether you tried to use Vigamox or Moxiza, bad idea, that you're injecting guarzantham into the eye. That very likely results in TAS. But no matter how careful you are and no matter how you do it, there's still an incidence of TAS with cefuroxime, with anything that you put in the eye, with viscoelastics, with irrigating fluid. But it caused the FDA to send out an alert about Moxie in particular. So the way I feel is, we're all waiting for that big pharma company to do the 20,000 patient study, and it'll have to enroll that many because the incidence of endophthalmitis, thank God, is low. So to show any statistically significant effect, it would be an impossibly expensive undertaking. But if you could get the drug mixed up, preservative-free, it's already on the cannula, and you just pop it open, sterile, and use it once and throw it away, that's my dream. And unfortunately, that's what I'm still waiting for. So I don't use it, though plenty of the people in our practice do. It's about a 50-50 split in our practice, I would say.
Yeah, the things that can potentially happen are scary, and it's the potential benefit of a theoretic lower risk of endophthalmitis. It's a tough call. All right, so Dr. Holland, let's go to you. So I'm going to bring up the photo again. We have this patient. What's the surgical plan here? How are we going to get this patient to see better, let alone better in a Symphony IOL?
Right. So, we have a situation where you have to make sure that all the inflammation's, been controlled. And is this the new baseline with severe endothelial damage and corneal edema? And this patient needs an endothelial keratoplasty and potentially an iridoplasty. And I think you have to decide which technique you want. I think, the technique you would consider is something that would allow the Symphony lens to work well. So you need to achieve excellent visual acuity. I think a standard DSEC and even an ultra-thin DSEC would not give you the visual acuity you wanted. So I think you're really looking at a DMEC or what a procedure we pioneered called nano-thin DSEC. So what are the advantages of the two procedures? Well, the problem with the DMEC here is your iris. I think it's, if you can't do a pupilloplasty and constrict that iris, you're going to have a bigger challenge of a successful DMEC with trauma to the tissue. I think one of the things that we have learned with nanothin DSEC, and that is a DSEC under 50 microns. And the reason why we chose 50 microns is the data on DALC versus PK shows that if you get cornea, a DALC cornea within 50 microns of decimase, the ultimate visual acuity is the same. And so we like the work that Massimo Bussin was doing with ultra-thin. We still felt that there was a role of DSEC, especially in high complex eyes, but we thought we had to get the tissue thinner. And so we have published our results showing that if you use DSEC tissue under 50 microns, you can get visual acuities comparable to DMEC. And so and their complication rates can be lower. You can use them in deep anterior chambers, with multiple eyes with multiple tubes, eyes with iris atrophy. If you look at, we did a prospective trial on DMEC versus nanothin DSEC, and the advantage of DMEC is the visual acuity recovery was faster. So at 6 weeks, those DMEC eyes saw a little bit better, but at 3 months, the visual acuities were identical. And so the concern I have here is, will the iris and the atrophy of the iris allow a good iridoplasty? I would probably opt for a nanothin DSEC, and I can achieve very good visual acuity in this eye.
Great, thank you for that, for those points. We're not doing nanothin DSEC yet at Wills. I'd love to try it. So what I decided to do here is a DMEC, but you're exactly right. To make that DMEC successful, we have to fix the iris. And also we've got an EDOF lens in, and to hopefully limit, unwanted dysphotopsias and aberrations. Hopefully by bringing the pupil down, that'll improve the quality of vision as well. So traditionally, the way we would do these pupilloplasties would be to use a long curved needle on a tenorproline suture and thread that along the inner pupil or along the pupil margin. And we have the same concerns that I had earlier, where we're passing this long needle across the surface of the eye through the iris. It can get a little out of control. And it's a really tough surgery. Ike Ahmed makes it look really easy on his YouTube videos, but we're not all Ike Ahmed. So what else could we do? So my fellow actually last year, Mike Saluski, was on Caranet, and he saw Steve Safran describe a new technique using tenoproline suture and a 31 gauge needle and use this for a pupilloplasty. So I'm going to go ahead and show that. We're going to go ahead and make 5 paracentesis incisions and 1 temporal incision, which we'll use for the DMEC. And what we're going to do is we're going to take a 31 gauge needle and bend it into a curve. And we're going to use that for the pupilloplasty. We'll take a tenoproline, cut the needle off, and feed it into the lumen of that needle. This can be a little meticulous and a little annoying sometimes, but it'll go through. And once you get it in enough, we're going to enter through a paracentesis. So now we have one end of the suture outside of the eye, one end of the suture inside the needle into the eye, and we're going to thread that needle with a micrograsper helping us through the iris, taking very small bites close to the margin of the pupil. We'll then pull the suture out from the needle, externalize the needle, and then externalize the suture in the paracentesis that's adjacent to what we started. So basically what we've done is we've threaded that suture through that segment of iris. So now we're just going to repeat. We'll thread the needle thread the proline through the needle, and then thread the needle along the edge of the iris. Again, taking small bites, trying to take as many as you can. Usually I try to aim for 3 to 5. We'll go ahead and pull that suture out of the needle, pull the needle out of the eye, and then externalize that suture through the next paracentesis. And we repeat this all the way along 360 degrees until we get to our starting point. So again, we'll go ahead and pull the suture out of the needle. And at this point, we're going to externalize that suture through the same paracentesis we started in. So now we have both ends of our proline suture externalized through the same paracentesis, and we can tie the knot. We'll go ahead and tie this knot, and I like to use what's a modified McCannell technique or the McAhmed technique, where we partially tie the knot outside of the eye, and then we'll internalize the knot using a micro holder, and then pull one tail of the suture inside of the eye towards us, and then one tail outside of the eye away from us. And by doing so, we can, in a very controlled fashion, tighten that suture and bring the pupil down to the appropriate size that we want. And here we're aiming for around 3 to 4 millimeters. We'll go ahead and carefully cut the tails of that suture, not cutting the knot because that would be terrible. And now all we have to do is the DMEC. Now, in TAS, unlike Fuchs dystrophy, it's a little bit tougher to strip decimase, and you want to make sure you get it all off. This is preloaded tissue from Corneogen. We'll go ahead and inject that, flatten the chamber. Unfortunately, this unscrolled very easily. We'll go ahead and get it into position, go ahead and inject our gas bubble, and essentially we're done at that point. And this case is really a great example of why I kind of love doing this type of surgery. So this is the patient before surgery, and this was a patient 1 month afterwards. So the cornea cleared up really nicely. The iris looks pretty good. It's not perfect, but it looks pretty good. And most importantly, the patient's happy with good vision afterwards. So I think that's a great point to end the talk. I hope everybody enjoyed it. Again, I'd like to thank Ash, Jen, and Bill for inviting me in, and a very big thank you to our celebrity panelists for all your expertise and great discussion.
Well, I mean, honestly, Biren, this has been absolutely brilliant. And I think the participation from the panelists has been nothing but supreme. And honestly, we did have 1 or 2 questions. And I think there was one question which was, I know it will be more invasive, but what if we put flanges under a scleral flap? Does it erode is a question that's come up. Parag, do you want to take that one? Have you put flanges under a scleral flap?
I haven't. I've either made a scleral flap or a flange, and I think there's some concern of the flange externalizing. So it's an additional step, but I think it would provide a little bit more, stability. But I'm not sure it's necessary for the vast majority of cases.
Right. Okay. Biren, have you tried something like that, or anybody on the group?
I have not tried anything like that. Have you tried anything like that?
Yeah, so I have tried it, but not long. We don't have a long enough follow up to kind of give a comment on it right now, because you at least need to have a 10-year follow up for this, because erosions can happen anytime.
Yeah, great
The
point.
problem with scleral flaps is over time, the sclera atrophies. So they look great for the first few years, but if you look back years and years later,
That's right.
it's probably an ischemic phenomenon, but the sclera over those, and we used to put flaps over knots, and then we wouldn't have sclera, we just have the knot and then the knot through the conch. So
Right.
I'm not sure it's going to add a lot to what the techniques that Baran has shown us tonight beautifully.
Right. So yeah, I mean, that was the only question that needed to be answered. And thank you so much, each and every one of you, for being here and doing this with us. At the closing, I really want to thank, first of all, Biren, for a wonderful presentation. Parag, Margaret, and Ed for really being there and giving their expert comments on such amazing, potentially educative platforms. And more importantly, we wanted to wish all the audiences Happy New Year 2021. Let this pandemic be behind us, hopefully this year. Also wanted to tell you all that in the next 48 hours, we will have this video up and running on our website with a little bit marginal editing here, there, wherever required, but nothing much. But 48 hours, it should be up on our website. So anybody who's missed it, or you want to share it with somebody else, risingeyestars.com is the website. And wanted to thank you all. Happy New Year. And let's hope to see you next month, same time. So we'll see you then. All right. Thank you, guys. Good
Thank
night.
you.
Bye. Thank you.
Bye.
Thank you.
Bye. Thank you.